Kia ora anō. Good morning. I first got involved in quality improvement in health services a long time ago, back in 1998. It was then that I attended a conference on quality and health services, and it was the first time I saw equity as one of the important domains of any quality improvement cycle that we introduced into our health services, and that really attracted me to quality improvement. And I don't know if you guys remember the New Zealand Council for Healthcare Standards. It was an organisation back then. I joined and became a surveyor for them, and we surveyed many health services around the country and in Australia actually. So here we are, we've gone full circle. It was equity that got me into quality improvement all those years ago, and it's equity that's dragged me into it again today. There are other domains that we were looking at. One was that services are safe, that services are timely, that services are effective for all people who use them, that services are efficient for all people who use them, and that services are patient-centred, and that they're equitable. Patient-centred / whānau-centred, because now we all know that Maori prefer whānau-based services rather than the individual patient-based services. So that's what got me into quality improvement, and that's what I'm talking about today. So health equity, what is it? How does it impact on mental health and addiction services? And how will we address it in this program? This is a huge opportunity because our knowledge and our data collection methodologies have improved since the 80s and the 90s, that I really believe we can actually do something about this. So for the purpose of this session, because I'm the Maori advisor, I'm focusing on Maori, but it could easily be Pacific, could be Samoan, could be Rarotongan, could be other Pacific races, could be Asian, could be refugee, but I'm talking about Māoris today. So when you see the Maori space, it's an equity program. You could fit in any of the other populations that we deal with, okay? Right. So we're talking in differences of health status, or the distribution of health determinants between different population groups. And in mental health, we all know there's no doubt that there are differences in health outcome between Māori and other groups in the populations that we serve. We know that Māori are 2 to 3 times more affected by mental health and addiction problems than non-Māori. Is that right? Yeah, you're right. Yeah. So I'm going to talk about 3 contributors to health inequity. One is social determinants, another is unconscious bias, and the last one I'm talking about is institutional racism. I'm sure you all know about these things, but let's talk about them anyway, because they do impact on the work that we do with consumers and families who use our services. We understand that social determinants are upstream things. They're not actually things that happen in the mental health services, but they are things that bring people into the mental health services because of education, our education system not working, consequently people being unemployed, low income, transport difficulties, urban policy development. They all impact on people who live in our communities. And these impacts have considerable social and economic costs on us and on our whānau. I think what we have to remember is that if you're from a lower economic class, your health risks are very high. So if you think about it in that respect, as long as we're having those problems upstream from the mental health services, and we're the ambulance at the bottom of the cliff, we're going to continue to have people tracking from those areas into the mental health and addiction services. So we have to improve our services to help those consumers and those families. Unconscious bias. We hear a lot about this term, but what is it? It's something we learn in our families. I found out several unconscious biases. I'm different. I was brought up by my grandparents, so the way I look at life, very different from my brothers and sisters. I'm more disciplined because of the biases given to me by my grandfather. I get really upset with my brothers and sisters because they're not as disciplined as I am. We all have these things, and we carry these things with us all the time, even into our workspaces. There's a website, Project Implicit, that if you want to find out more about your own biases, go there. It's even got a tool, an unconscious bias tool for mental health and addiction workers. You can find out. I found out many interesting things about myself, as I said. We won't talk about those. Yeah. But you can rate your own test yourself in unconscious bias. I've got Dr. Carla Hokama up there. She's a bit of an expert in this area for unconscious bias in Maori in health. Really interesting person. So some of her research, the bits that I've read, the parts that stuck with me are around the perception of medical professionals of Maori consumers in whānau. What did they say? That the assumption was from these people, unconscious bias was that Maori was sickly and non-compliant, and that Maori cultural practices and lifestyles were the cause of their illness and disease. I mean, some of the research might very well bear out some of these, let's say, unconscious bias, but you should really find out the facts before you start stereotyping people, is what I'm trying to say. Do we stereotype people in mental health services? Well, maybe we do. I mean, I used to work in mental health services. I remember when the phone rang, we found out a certain person was coming in, we got the room ready. I don't think we do that these days. I think everyone's sort of more professional in their approach, and they do a proper assessment before they decide what the best treatment is for people who come into the service. But this used to happen particularly with well-known Maori patients who use the services. If you want to know more about Dr. Hokama's research, just put her name into the Google Explorer space. It'll take you right into her research website. How am I doing for time? I'll talk a bit about institutional racism. Okay. This is the definition of the National Health Promotion Forum, that it's an entrenched pattern of differential access to material resources and power determined by race, which advantages one group over another group. So if you're related to your work areas, I used to think when I was at work, because I used to work in what they call the refractory wards, because in those days I was a registered nurse. I was quite a big fella. I used to be a prop when I was younger. You probably wouldn't believe it, but Simon knows. Just saying. Anyway, I used to end up working in those wards, and I got to thinking as I was working in there one night. There was knocking on the door, and I went and talked to the patient in the room. It suddenly struck me that this is all wrong. The patient in the room, of course, was a Maori. And I just thought about what I'd grown up with, the values that I'd grown up with, and I applied them to the situation I was in, and I had a epiphany that the way we were treating this person was all wrong. And after that, I began to really think about what our services were providing for Maori consumers who are using them. And from that day on, I changed my whole approach to nursing. I threw some of the nursing profession out the window and started thinking from the Maori perspective. And it was all because I questioned the treatment that we were giving these people. Well, this particular person, and for every Maori person after that. Because in my mind, I was arguing that because the policy settings of these services were based on New Zealand mainstream or Western psychosocial concepts, that I didn't think Maori people were getting a fair deal, to be quite honest. I mean, if I was saying it plain, that's what I would say. I don't know if the services have changed because I left them 21 years ago, and moved into the wider health sector, and then I retired. But I'm hoping that we can see this as an opportunity, if they haven't changed, to actually change them so that they can address some of these inequity issues. We can't keep on doing the same old if the outcomes are telling us that the system is not working. What will happen is there'll be divergence instead of convergence. We want equity to show that health outcomes are the same for Maori as they are for Pacific, as they are for mainstream, don't we? That's what we want. But at the moment, the tracking is moving parallel. The danger is, of course, that we're going to start going out like that again. So we really do need to change. So this is draft. This is a framework that we put together, and including the Maori Advisory Group. We had a call about this yesterday, that we put together using all of the technologies that you've been introduced to as a result of this work that you're doing. Always remembering that for Maori, the Treaty of Waitangi sits over the top of everything. It's our foundation document in health. It's the foundation of our health. So while we talk about equity, we'll always put the treaty first. That's our position. That's the Maori position. So we have the equity framework. We have the model for improvement, PDSA, which is what you're training in, or you've been trained in to use in the Zero Seclusion program. And that, of course, permeates all of the work that you're doing. But as well as that, the principles of the Treaty of Waitangi are permeating too, and we all know what they are, that we're working in a partnership, that Māori are participating in this partnership, and that we're there to protect the health rights of everyone. Okay? At the same time, we have Māori concepts, we have the equity measuring framework and tool, and we have Western biopsychosocial concepts also being incorporated in the work that you're doing. And all of this goes into the co-design process that you're all involved in, I suspect, or I expect. So this really is a representation of what you're doing anyway within your groups. But we're asking you to seriously regard the inequities related to Māori that the measuring framework will throw up. Because if your performance measures are the percentage of time people spend in seclusion, that's one of them, isn't it? Yeah. That's one of the measures you're using. Yeah. What are the other two?
Length of time in seclusion.
Length of time in seclusion.
Yeah. And the number of seclusions.
And the number of seclusions. I've no doubt that the Māori relationship to these measures will throw up inequities. All right? What we've never done in the past is we've never taken those measures and said, why is that happening? Or how can we fix that? So we're not introducing any new measures. We're just asking you to regard the measures as part of your analysing and problem solving, your PDSA cycles. So while you're doing all of the other data that comes in as a result of your measuring framework, collect the Māori data as well, or the Pacific data, or the Asian data, because you're going to have to work on all of them. I mean, you agree with this, don't you? Okay. Yeah, so we've had the willingness to do it, but never the wisdom is what I'll say. We wanted to do it, but we didn't know how to do it. Well, now we all want to do it, we know how to do it, so let's get on with it.